All right, we're live.
Good morning. It is February 10th. This is the Senate Health and Welfare Committee. And this morning, we're going to be looking at some of the federal dollars that are coming to us and have invited Joint Fiscal, Steve Klein, to be with us, as well as Sarah Clark from AHS, to give us an understanding as much as possible on the money available and that what it's directed for, and any guidelines that we currently understand that the federal government has put in place. So that's our first topic, and thank you both for being here. Steve, I'm going to turn it over to you and then let you direct the traffic on this one.
Yeah, and actually, this is Steve Klein from Joint Fiscal, and I'm just getting my life in gear here. Yeah, so I think what I'll probably do is go back and forth a little bit because Sarah is really the expert on a lot of chunks of this. And maybe what we should do is pull up, and either I can do it or Nellie could, just the where we are. We have a November 9th, sort of what we got in the way of federal money, because it does talk about a lot of these issues. And so maybe what I thought we'd do is go through that as our base. What makes sense, Nellie?
Do you want to have Nellie pull this up, or do you want to pull it up? It's up to you.
Or I can send it to anybody. Some committees prefer not to pull things up and just have it on their own screen. I mean, how do you tend to operate?
We like it on the screen.
Okay, good.
Yeah, no,
Steve, you are a co-host, so you can share your screen if you're comfortable.
So I'm gonna select an application or window that I want to share. Yes, I think I can do this. I'm not an expert on sharing screens, so we'll see what happens.
Well, but that came up so quickly. You must be an expert.
God, okay, good.
Yeah.
So what you should have on your screen, which somehow I don't, but that's okay. That's just like
it is. It would be great if you could make it larger.
Okay, let's see.
Yeah.
And it's basically okay. So what this is we track from Washington sort of what we're getting in the way of the state in different areas. And what I thought I'd do is go through this from the top and just sort of flag where the money is. And this is the December 27th bill. And some of this is less related to your work, but I'm going to talk about the AHS or the human services implications of it as we go through. And we get updates of this every week. So this is yesterday's update. The big one that you're hearing a lot about is the first one, the emergency rental assistance, and $200 million for Vermont. And you notice it says Vermont share 0.8%. So what that says is Vermont normally is about 0.187% of the U.S. population, or maybe we always say round it off to 0.2. So we got 4 times our weight as far as what we received in rental assistance, and that's because they used the same small state minimums that was used in the March bill for the CRF. So this is a lot of money. There's a grant that's been received by Joint Fiscal. They're going through it. Some states, what happens in Vermont, and a lot of this is just background, which you all know, is that the legislature gets involved in approving grants. In many states, the governor just goes and does what he wants to do. So some states have moved quicker than we have. We're a little slower because our process involves the legislative grant approval. But from what we understand, the advocates have gotten together and have plans. And I think what Sarah will, in a few minutes, go through some of the human services aspect of this. But it's a lot of money. It definitely has very restricted use to people at 80% below the 80. What is it? 80% of the average poverty, median poverty or less. And
I think it's a regional median income.
Yeah.
The only reason I know that is because I was at Joint Fiscal yesterday.
Good. And you were listening harder than I was.
Yeah,
and the thing is that we have to have 65% of this at least obligated by September. So it's a fairly tight timeline. And what happens is any money that isn't obligated by then gets redistributed, or a share of money gets redistributed between states that have need. So there's a lot of pressure to get this out quickly. And we'll talk about that in a minute. So why don't I will move on from that, and unless there's questions, and I can actually just, maybe I should just have Sarah, do you want to talk about that one, or do you want to, would it be easier to just do your PowerPoint all at once?
I can just mention a few things about that, Steve. You've captured a lot of it. I'd say as it relates to AHS, of that $200 million in the AA1 that was presented to the Joint Fiscal Committee yesterday, there's $30 million that's targeted to come to the Department for Children and Families. Though there is kind of a high-level plan for how we would use those funds, I think what's needed is additional guidance from the federal government in order for us to put the final plan together. I understand from yesterday's Joint Fiscal Committee that I think there will be additional materials provided to the legislature to help you evaluate the plan surrounding that $200 million.
Can I just ask a quick question here, please, Senator Lyons?
Yeah, sure. Let me ask the question of Steve and Sarah first. Do you want questions?
Yeah, I think you might as well do questions as we go through it.
Okay, that some people don't like that, but this is great. So, and just for my committee, I cannot see you all, so you're going to have to speak up. So Senator Hooker.
Thank you. So the money, the rental assistance, does this go directly to the landlords?
Well, I'll start it. The answer is no. It came to the state, and what will happen is big chunks of this will go to the landlords. Yes, but the money may go to other programs. There's a whole series of programs that can fit their criteria, and I think that's what Sarah Clark was talking about. They'll be developing some uses for the money that may not be landlord specific. So it'll be a whole variety of programs. Sarah, is that right in your mind, or?
Yeah, that's right, Steve. And I think what you and I have talked about is it would likely be helpful for the committee to receive testimony from Josh Hanford from ACCD and Sarah Phillips from the Department for Children and Families, who are more involved in the weeds in terms of how this program will be administered.
Yeah, that's a great point.
Okay.
Okay, so we'll keep moving. The education one, I'm not going to spend a lot of time on, but I just want to flag it because we got there's the education one is really complex in the sense that there's the governor's emergency education relief fund, which is a small chunk, $1.9 million, which has not been allocated yet, and that's sort of money available. And private schools money, there's money that we have to offer to private schools. They may or may not use all 4 million of that. 200,000 is for administrative expenses. So those two are sort of small, but we're going to have to figure out how to allocate the 1.9, or somebody will. The K through 12 money, the schools have, from the first bill, we had 26 million. Now we have the equivalent of 114 million of money that goes to schools. So you have about 140 million of money going out to schools. There's a lot of talk about what do they use it for? Can we find a way to take that and use it to address some of the, on a short-term basis, some of the concerns that the weighting study is built on, poverty issues, ESL, access issues, and to give us time to really think creatively about weighting and long-term changes to the fund. The other thing that comes up in the money going to schools is, can we free up some, can we use some of that, free up some education fund and use that for more mental health issues, which are coming up and in schools. And the other thing, which is as schools are getting this pretty sizable chunk of money, 146, not all of it needs to necessarily be pandemic related, a big chunk of it will. Do we sort of siphon off money between, maybe the AHS uses more of the special ed Medicaid money? Traditionally, they've used very little and let the excess roll into the ed fund. Is there a way that we can move that? Because mental health, as you all know, between the human service area and schools, there's a lot of a very porous relationship. And schools are always complaining, why are they paying for human services and vice versa? But because of this large amount of money coming into schools, there is room to look at that relationship between the two. Let me just flag, there's also another, I would say $10 million available. We gave $3.5 million to Burlington to deal with its PCBs. There's another 10 million or so left of governor's money that could be allocated in different ways. They're talking about school construction issues, a more substantial program to look at environmental hazards in schools, and those will be subjects to deal with too. So that's sort of my K through 12 land. Sarah, did you have any thoughts on that, or I don't know if that's come up in your world?
Nope.
Steve, Madam Chair, may I just, I'm here now. Sorry, I was late. I was
Oh, go right ahead.
speaking with a constituent. There's so little time to actually talk to people these days. Steve, I'm really glad to hear that people are thinking about ways to distribute that funding that for K-12 schools that may be somewhat based on the weighting study. As you know, I had a proposal for that started last year. So I certainly would be happy to get back to that and work on a proposal for that if nobody else is. But you have my original thoughts on that, or my thoughts on that from last year, because I think that's really important that we find an equitable way to distribute it and not just a reimbursement based way, because that favors certain school districts over the other and doesn't necessarily target it to the ones that need it the most. So I just wanted to thank you for that.
Well, no, and just to be clarified on that, this would have to be distributed. Title I requires a distribution formula federally, but the question is, if we distribute it with the Title I formula, could we then pull back some of the Ed Fund dollars and then reallocate that into a block grant to meet some of the needs you're talking about? So that it wouldn't be a direct, it might be an indirect. The other thought that's being played with is do we, in the process of distributing Title I, do we add some conditions that they need to report back on how they used it to deal with some of these issues, like, you know, the ESL or the access issues or low-income issues, because that would help us gain information on how we could best, what programs we could do that would help us design the weighting study for a longer term. I mean, but there are ways to do this, to use this creatively. It's just not going to be, we can't directly control the money. We can just indirectly mess with it a little bit.
Right. And I appreciate that creativity. So thank you.
Just also that this area, well, we will have something to say probably about the mental health appropriation, but the bulk of this is going to be handled in the education committee. So, but
and that I think your point's a good one. That may be an area, if you have time to spend some time on, not it's just the mental health in the school, but the whole human services education interaction, because that's going to be up for discussion.
Yes, it is.
The K through 12, I mean, the higher ed, the state colleges got an extra a little over $10 million, of which they think $5 million they can definitely use. They are trying to figure out a way to use more. So that'll help us a little bit with our higher, the VS state colleges sort of needs. We're working with them on trying to use a little more of that. There's a lot of room for, I mean, that's small money. The whole, one of the, as you all know, and this is an area where it's not directly a committee area, but as we're looking at the changes of the state colleges and the ongoing need for funding, you know, how do we imbue that with creativity? How do we look at the issues? And I know that some of you have raised these issues, like last summer, there was a proposal to give free tuition to for the community colleges for people that were affected by the COVID thing, and it was oversubscribed. I mean, do we use some of, in helping the state colleges, are there ways we can do it that actually strengthen the communities they operate in, or provide resources to students? And it's something that we're going to be putting a lot of money in the colleges, and you want to be knowing that over the next 3 or 4 years or 5 years, whatever the stretch the time takes, that you end up with a system that's can keep going and be useful. So that's just that's not just the state funds, federal funds, that's sort of a state fund issue. Human services, I think why don't I turn it over to Sarah, if you want to go through these, where you are on this.
Sure, I can do that, Steve. And, you know, really, I think I was here last, maybe it was about 3 weeks ago. Time flies and we lose all sense of time. And so I was planning to focus on things that have changed since we were here the last time. And so as it relates to the Child Care and Development Block Grant, we've actually received our award, our notice of award from the federal government, and it is in the amount of the $12.2 million that you see on this sheet. What I'll highlight for you is that it's a couple $100,000 less than what I previously testified to once we received the actual award. The Department for Children and Families is evaluating the guidance associated with that award and coming up with a plan for how we're going to distribute those funds. And then as we move down the list.
Just briefly, as you go through, if there's any indication whatsoever about what some of the broader guidance statements
Sure.
are, yeah, just just let us know, that's all.
Sure, and maybe so as it relates to Child Care and Development Block Grant, those funds are issued underneath our existing federal program and can be used by states with some flexibility, but essentially to support childcare providers during closures or reduced enrollment as a result of the pandemic. Could be used to expand assistance to this essential worker population, as well as some payment relief to working families. And so, as I said, DCF is working to come up with a plan for how we'll use those dollars. But I assume it'll be similar to how we've used earlier tranches of funding.
So, and then along the lines of the idea that for providers who have lost their kids, then the question arises about how the hubs may have actually brought that count back level, and how that's all going to sugar off, I guess. So I don't know what the thinking is right now in DCF, but that would be something that I would want to think about.
Yeah, it may be something that this committee would want Commissioner Brown and his team to come in and give you more details on the specific plan. As you know, Vermont has provided a lot of relief to childcare providers. And so as we get these new tranches of funds, making sure that we're using them in an effective manner to augment the relief we've already provided. But it's definitely an ongoing and very important issue. Going down the list, I don't, looking at the home delivered meals, the long-term care ombudsman, there haven't really been changes since I was in a few weeks ago. Same with the Centers for Disease Control and Prevention funds, the CDC funding. Those are the awards that Vermont has received through our Department of Health, the $35.9 million, as well as the $5.6 million specific to vaccines. The health department is working with the guidance that the federal government has provided to develop the budget surrounding the use of those funds.
So again, this is where we may need to take some testimony as time goes along, simply because we provided guidance for the last, for the CARES funding, CRF stuff. This is new. And are the needs same or comparable? So it would be the same organizations. And I know there's different funding guidelines that come from CDC on vaccine preparedness and so on. So I don't know if you have any inkling of what is being discussed.
Not yet, because it's still in the health department realm, but our process is such that I will be brought in as we get closer, as they formulate the plan. In my presentation that I provided to the committee, I do talk about one of the big pieces of news that's not captured on this information that Steve has provided is the announcements from FEMA over the last couple of weeks. That has very significant implications on our funding matrix as it relates to the COVID response. And so perhaps after we get through this list of programs, we can turn to my slides and I can address some of the other funding issues. But really,
well, if you want to switch to your presentation, either way, that's fine.
Okay, yeah, because on this list, there haven't really been any other changes related to human services that we haven't talked about from when I was here the last time.
Okay, that's good. Why don't we do that? Why don't we do as Steve has suggested?
Just switch to your list, and then we'll go through a couple other things that are on the watch list, as my dentist says sometimes.
Oh dear, Steve.
Sarah, we don't have your slides.
Yeah,
on
I
our-
sent them to Nellie, so I'm going to
Okay,
share my
so maybe they're
screen.
up. I just have to refresh.
They're on the website.
Okay,
Okay, so let me,
there they are.
okay, I should be sharing my screen. So,
Okay.
okay. So as I discussed, I think well, let me start with the FMAP bump. So reminder, FMAP stands for Federal Medical Assistance Percentage, and it's really the rate at which the federal government matches the state's Medicaid program. I believe, as this committee is aware, going back to last year, the federal government provided a 6.2% FMAP bump in response to the pandemic. This essentially means that Vermont is leveraging 0.2 percentage points more of federal funding as it relates to the Medicaid program. This was incorporated into the 21 budget that was passed by the legislature last year and continues to be a conversation as it relates to the 21 budget adjustment and the 22 budget going forward. What is new in since I was with the committee last, is that the Biden administration obviously has come into power, I think, since I last testified in this committee. As a result of that, the Biden administration, through their Health and Human Services Agency, issued a letter to governors that essentially says that the public health emergency will likely remain in place for the entirety of 2021. The Biden administration is doing this in an effort to provide some stability and expectation that states can have in terms of continued support from Health and Human Services. This extends to the FMAP bump. With this guidance of the public health emergency extending likely through calendar year 2021, it means that the FMAP bump will likely be in place through March of 2022, which essentially means we're leveraging additional federal dollars, which will give the state some flexibility in terms of the general fund that frees up.
Wait, Sarah,
Yes.
I'm sorry to interrupt. I'm looking at your slide, and the second and third bullets seem to contradict each other. You said the FMAP bump enhancement to continue through June 2021, and then through the entirety of 2021, and then through March 2022.
Yes, thank you, Senator Hardy. And my apologies. When I updated this last night, I was just adding on from my last testimony. So the first two bullet points were when I was with you last. The last big bullet point is what we've received in terms of updates from the federal government in the last couple of weeks. I will edit my presentation and give it to you again, Nellie, so that you can post the updated version on the website. But essentially, they're indicating that they will likely continue the public health emergency, which will mean they will likely extend the FMAP bump through March of 2022.
Okay.
I keep saying the word likely because that is what was written in the letters. And so from a CFO perspective for the Agency of Human Services, I'm always very cautious until I see the official notice. But I think it is an attempt to provide some stability and predictability for our funding streams to states.
I kind of, I think leaving it, as long as it's clear that a new letter will change it, it shows a historical development. Well, yeah.
Can I, Sarah?
Go ahead. So
you-
wait, hold it, Senator. Steve Klein, you.
Well, I just wanted to
comment.
have Sarah clarify. The governor's budget is built on through June, I think. Is that correct?
Okay.
So what you really are talking about, if you can go all the way to March, you're talking about maybe $66 million of additional money that the governor didn't book.
High level estimate, Steve. Yes.
So,
And
but that's not been, but that has not been included in the governor's budget as of yet.
Right.
Correct.
Got it.
Public health emergency and the FMAP bump work is that we receive notice on a quarter by quarter basis when they extend the public health emergency. So we don't know until they officially extend it through that time period, but they're trying to signal that they will likely extend it through the end of calendar year 2021.
Okay. It would be nice if they just extended it.
It would.
Senator Hooker.
Thank you. So Sarah, can you just explain what the 6.2 FMAP bump would be used for?
Yeah, it's essentially it's in support of the Medicaid program. So, that's across various areas of the Agency of Human Services. However, to the extent that we're leveraging additional federal dollars in support of the Medicaid program, it does free up general fund that can be invested in other areas.
But does this money have to be used for costs related to COVID? For instance, we were in a meeting with VNAs this morning who said that if they didn't have a loss, they didn't get the bump.
No, this 6.2% is in response to the pandemic, but its intent is to be used on the Medicaid program, which doesn't have to necessarily be pandemic related.
Okay, thank you.
Are there any other questions about the FMAP bump before I continue? Okay, so as I indicated earlier, some of the big news that we've received over the last couple of weeks is that President Biden and the White House have issued directives that are allowing FEMA to pay 100% federal dollars for the costs of activities related to the pandemic that had been previously determined eligible by FEMA. This 100% federal funding is an adjustment. Typically, FEMA offers 75% funding, and the states have to come up with 25% share. As it relates to this pandemic, state of Vermont has been using the Coronavirus Relief Fund as the 25% match on FEMA projects. But now that FEMA has indicated that it's going to be 100% federal dollars, and it's also retroactive back to January of 2020 through September 30th of 2021. This is pretty significant news for the state of Vermont. It means that all work eligible under FEMA's existing COVID-19 policies, including increasing medical capacity, non-congregate sheltering, and emergency feeding distribution, will be reimbursed at 100% federal share. FEMA is also we're told, going to kind of automatically update their agreements with states on a project-by-project basis to reflect this transition from 75% FEMA federal funds to 100%. No action is going to be required by the states. What this means for Vermont is that coronavirus relief funds that had previously been dedicated to be the 25% match will essentially be available to either provide continued support in the areas at the Agency of Human Services or potentially for reallocation. However, as the CFO of the Agency of Human Services, it's also very important that we understand the process to receive the FEMA federal funds and that we know how we're going to transition the fund sources before we actually reallocate the CRF. I just want to make sure that we cover our obligations before we move away from the Coronavirus Relief Fund. But this is extremely good news from a federal funding perspective for the state of Vermont.
Do you have any idea of how much money we're talking about that has already been obligated for the match?
So it is a complicated analysis to get to that exact figure. And Steve knows I hate to put numbers out there before we vetted it, but it is significant. In the tens of millions is what I would likely anticipate. I think that we will be moving over the next couple of weeks to having a more solid estimate. And you'll probably want me to come back. Steve and I will bring our roadshow back to the committee and we can give you an update on what that figure would be.
Excellent. Yes, no, thank you. There are significant implications as we're talking about each of these areas for the length of time it's going to take us to put the budget together. So
yeah,
I don't know what that's going to look like. Maybe Steve.
Yeah, and you're right. And this is we're in a very weird time because first of all, it's worse for the House than you. The Senate going second gives you a little more knowledge when you actually do the budget. But if you think about it, having the 40 to 60 million more FMAP to have this number, which Sarah Clark sort of indicated was in the tens of millions. It could be more than 10. It could be several tens of millions. And this is more money. And then the other thing we are looking at is a new federal relief bill, which we're just beginning to get a flavor of, that could be substantially more money. So, you know, in a sense, when you look at we had a discussion yesterday of the render assistance, which, and there was a lot of questions about, well, how much do we micromanage? How much do we just let that go? When you know you have a lot of major decisions coming up in the future over a lot more money, where you have a lot of flexibility, that I think the committee, joint fiscal, and I can't really speak for them, obviously, but they may say, look, this one, let's just let it go. There seems to be enough people thinking about it. Let's let that render assistance happen, because you're going to be in a situation that's not overly comfortable with the legislature, which is just so much coming in all the time that you just can't manage it all in down to every little bit. You have to let things happen, because there is it's a pretty substantial. I think we're just seeing the beginning of this. The Biden administration has taken every step they can to loosen the available resources, and our congressional delegation is working to help us there too. So it's a very unusual budgeting period.
Yeah.
With one
Right.
warning, I always have to say, this is a limited period of time, 1 or 2 years. You know,
Right.
you can't build long-term liabilities, because, you know, we're long-term. We still have this negative, you know, issue going on.
Oh, yes. Thank you.
To give
There's
you
a
some
lot to discuss there, but we won't right now.
Okay.
There's a lot to discuss. And I think the committee has an understanding of where AHS has used FEMA funds, which is to pay non-congregate housing. So this is our motel program, as well as the related services surrounding that program, to include security and food for those individuals. The other area related to FEMA where we've gotten some clarification in the last couple of weeks is that 100% FEMA federal dollars can be used to pay for COVID community-based testing, as well as vaccine clinics and the supporting infrastructure surrounding those vaccine clinics. And so the Agency of Human Services is working with the COVID Financial Office and Guidehouse and the Department of Public Safety to determine, you know, what that looks like from a FEMA reimbursement perspective. Why this is good news is that, if you recall, the ELC grants that the health department receives, which is the epidemiology laboratory capacity, roughly $100 million of funds that they have used as it relates to the pandemic response. Those funds can also be used for testing and vaccination. So FEMA coming in with 100% federal dollars provides the assurance that we need that the federal government is really going to fully cover these important activities, vaccination and testing. So a lot of really positive news from FEMA in the last couple of weeks. The other thing I'll highlight for this committee, the federal government is still providing direct support to healthcare providers through the Health and Human Services Agency, through the Provider Relief Fund. What's changed on this slide from when I'm here last, if you look at the second big bullet and the 2 sub bullets underneath it, when I was here in the mid-January, I had provided data to the committee that as of January 8th, 1,137 Vermont healthcare providers had received $207 million directly from the federal government. Since that time, you can see that's actually increased by roughly $3 million over the span of a month. And so that support direct from the federal government is ongoing, which I think is important to understand, that there, you know, besides the relief that the state has provided, that there is federal support coming to shore up our healthcare system. Also good news. We've already talked about the emergency rental assistance program. We've also talked about the Child Care and Development Block Grant. And then my last slide, Steve has already alluded to, spoke about briefly, is that there's more money coming. And the Biden administration has made a $1.9 trillion proposal to Congress that is currently being reviewed and taken up, but will reflect more money coming to Vermont. And more details on this to come. And
Okay. Thank you. Questions committee for Steve or Sarah? this is go ahead, Senator Hooker.
Do we know if the small state minimum will apply again with this new tranche?
You mean the new money in Washington?
1.9, yeah.
Maybe I'm missing the 1.9 being,
The
Billion
new
from the federal
1.9 trillion that
If-
hasn't,
If that goes through, will the small state minimum?
oh, that, yeah. So the answer is somewhat it will. And, we just got last night at some ungodly hour, the beginnings of a picture of what this might look like. And it'll be less of a small state minimum, but it'll be there. So like, I think we got 1.25 billion. I think the money will be more flexible. It'll cover revenue. It will be, we did an estimate this morning and last night about that, and I think it could be in the neighborhood of half as much money, but still, that's a lot of money. I mean, we're talking 600 million, give or take, and it's everything's up in the air in Washington. But we've seen the language, and there is a smaller small state minimum, and more money that goes based on unemployment. Because of the way Vermont treats unemployment, we're probably going to get a very small share of that. But this is something up in the air. And I think that this is just the state dollars. What's really, and this is sort of beyond your world right now, but they're also putting aside money for counties and town and local government. And it's a real problem because Vermont doesn't really have
we
counties.
don't have counties.
And so the question really is how that gets interpreted. And so that's what we're working with the congressional folk on right now is, given that we don't have counties, can they find a way to recognize that? But in some states, like, California, I mean, counties are everything, and a lot of services are provided to counties. So it's a real case of Washington in a very short time trying to build a one-size-fits-all structure. And so we don't, even if we lose the county money and the local money, it's still a lot of money.
Right. That's one of the things as you're talking about the county issue. If you just look across the lake at New York State, where the county actually has some authority over Medicaid dollars.
Yeah.
So it might be that there's an infusion in those counties for additional Medicaid support. I mean, I guess I'd want to make sure that we're not held liable, in any way, penalized for not having counties. So thanks for bringing that up.
Right. And that'll be something it'll unfold over the next few weeks. This goes to the fact that you're the Senate. I think this bill is on a track that we may see by the end of February at the latest,
Wow.
this happening. And so it'll be very troublesome for the House because they tend to do the markup on the budget in March and be done with it by March 20th. So they're going to get this toward the end of their process. You're going to have a little bit more time to process it.
Yeah. Okay. Thank you. So listen, we've obviously kept you over your schedule, but we greatly appreciate the update on this, both of you. And I think it would be helpful just to stay in touch with Nolan or Nellie or me and let us know when the time is ripe. So for the next update, we'll also be getting nervous about it. So we'll reach out, but in particular, any of the guidance documents around the AHS stuff or mental health in schools and that kind of information be very useful.
Yeah. Oh, and the other caveat is you can start, whether it's the renters, as Sarah mentioned, learning more about the rental assistance program, learning more about, spending a little bit of time on the interaction between education and AHS and how those two coincide. A lot of the DA issues involve schools, and just anything you can do to sort of build up your strength. So when these monies hit, you'll be able to think creatively about them.
Oh, this committee is extremely creative.
Right. Okay.
All right. Thank you very much. We're gonna move off of this topic. I don't see any more hands raised. And again, thank you. You
Thank you.
done a good job as usual. Appreciate it. So we'll move on now to Jen is here. Oh, before we move on to Jen, hang on a second. I've got Sarah's up and I don't have that. Okay. Jen, are you here? There you are. Okay. Yeah, so we, I think we'll move right into the flexibility bill. We have S42 on. We've had some communication from folks regarding S42. That might take us 10 or 15 minutes, but I think as long as Jen is here, let's go right into the flexibility bill. Whether we get to S22 today is problematic, but because we do want to finish our discussion on S42. So we'll just take the flexibility bill first, then we'll see where we go with S42 after that. So Jen, thanks for being here.
Sure, no problem. Do you want me to put up the bill and kind of pick up where we left off yesterday?
Yeah, why don't we do that? And I know that, what were we on? What can remind us where we were?
Yeah, so you were talking about the out-of-state healthcare providers and whether they would need to notify the Board of Medical Practice or OPR if they were planning to provide telehealth. And then we also had added those pieces around Medical Reserve Corps and the FQHCs.
Okay, so let me, before I'm going to turn this to Jessa Barnard, who asked to comment on this. But Nellie, I think Lauren Hibbert was also interested in commenting on this. Has she responded?
I sent her the Zoom information, and she has the agenda, so she knows when it is. I'll bump it up and make sure she knows we're talking about it now.
All right, that's good. Yeah, good. Because we do want to hear from her from OPR. So just remind us, Jen, what we currently have in the bill, and then we'll ask Jessa for her comments, and hopefully Lauren Hibbert will also Zoom in.
Sure. Well, why don't I put up the language for a minute so I can show you the various
Yep.
pieces, because we didn't get all the way through it, but I think it might be more efficient use of Jessa's time and Lauren's time if they can respond to the whole, that whole piece around the providers. So let me make sure I'm pulling up the right thing. There we go. Okay. Should be able to see that. I will move.
Yeah.
And it was down in sections. Here we go. So it's sections really 17 and 18. And so just to take you through what the changes were, this
Begins
would,
on page bottom of 6 and then 7
Right.
and 8.
right. So it would have through March 31st, 2022, this would have what we've been sort of shorthand calling deemed licensure. So deeming someone who's licensed, certified, or registered to provide healthcare services in another state as so someone who is already licensed in another state would be deemed to be licensed to provide services here using telehealth. So right now you have in the existing law using telehealth or as part of the staff of a licensed facility. And then we get into the notice requirement just for the people on the staff of a licensed facility. This would change the language to say that they would be deemed licensed to provide services to a patient located in Vermont using telehealth as a volunteer member of the Medical Reserve Corps or as part of the staff of a licensed facility or federally qualified health center. And then same requirements about them being in good standing in the other state and not subject to professional disciplinary proceedings or affirmatively barred from practice here. And then it would have language. So currently, someone who plans to provide healthcare services in Vermont as part of the staff of a licensed facility has to submit or have submitted on their behalf their name and contact information. This would apply to anyone who was going in under this subsection A. So that would be telehealth, Medical Reserve Corps, or staff of a licensed facility or FQHC. Any of those people would have to submit or have submitted their name, contact information, all jurisdictions where they hold a license, certificate, or registration, whether they will be providing services using telehealth, and where they will be practicing. So it's an expansion both of who could be deemed to practice here, but also what the notice requirements and having everyone have to provide notice. And then it would create an affirmative requirement for the Board of Medical Practice and OPR to provide appropriate notice of the March 31st, 2022 expiration date of this section to each healthcare professional who's providing healthcare services in Vermont under this section. They would have to provide that to each healthcare professional who's providing services, to the Medical Reserve Corps so that they could tell people, and to any healthcare facility or FQHC at which a healthcare professional is providing services. So that was sort of my first stab at a notice requirement. And then I'm gonna, if it's okay, I'm gonna run straight through the inactive licensees and then, or retirees, but renamed here so that we get all these issues on the table, and then you can discuss them. So section 18, I changed the language from retired healthcare professionals to inactive licensees. I think you heard from the Board of Medical Practice last week that it's not just retired people, but people who might have let their license lapse or gone inactive. So this would change the title of the section to be inactive licensees, and it would refer to people, instead of them having retired, it would be through the extended date of March 31st, 2022, a former healthcare professional whose Vermont license, certificate, or registration became inactive not more than 3 years earlier and was in good standing at the time it became inactive. So moving away from the concept of retired, could provide healthcare services to a patient in Vermont using telehealth as a volunteer member of the Medical Reserve Corps or as part of the staff of a licensed facility or FQHC. And then again, their information would have to be submitted. They would have to submit their name, contact information, and all jurisdictions in which they hold a license and whether they will be providing services using telehealth. So under the existing law, the requirement to notify if they are providing telehealth is also here, which is a little different from the deemed licensure in other states piece where they didn't have to notify if they were doing telehealth. And then I made similar notice requirement language in here. And then also changed that language around the retiree to inactive for the people who'd been out of practice longer. I think that was it for that section. So I know there's a lot of words and a lot of changes there, but I just wanted to kind of put it all on the table so that you could talk about it. And I know there was at least one hand. I don't know if you want to.
We have it. Questions committee for Jen. Senator Hooker, then Senator Hardy.
So Jen, an inactive licensed person, or a person who wants to sort of come out of retirement or start doing telemedicine would have to register.
So under the way the law is currently written, there was not the distinction in the modality as far as whether it was going to be on the staff of a licensed facility or through telehealth for the retirees, or now what we're calling inactive licensees. So they have been supposed to be notifying OPR and the Board of Medical Practice if they're kind of coming out of retirement or reactivating, even though they have an inactive license, as opposed to someone who's licensed in another state who does not currently have to provide notice to do telehealth.
So there's that differential.
Right. So if you change the language the way it's in the bill here in this draft, you would no longer have that differential. So you would be kind of turning on that notification requirement for the out-of-state telehealth providers.
Thanks.
Okay. Senator Hardy.
Thank you. I apologize. Senator Hooker may have just asked the question I was going to ask, but Nellie asked me to respond to an email at the same time, so I was a little distracted. I'm sorry. But my question or thought was, we were talking about if we were adding on a new requirement in the middle of the pandemic, that might not be such a good thing. But we are adding Medical Reserve Corps and the FQHC, and maybe we can compromise by asking them to notify, but not the telehealth people. if that makes sense. But I'm also interested to hear what Lauren and Jessa have to say. So
Yeah, why don't we listen to what Jessa and Lauren have to say, and then we can open it up for discussion. So, and I'm going to go to both of you are here. I'm going to go to Jessa first, and then to Lauren. And thank you both for being here. So, Jessa, thank you.
Sure. Thanks so much for having me. Jessa Barnard with the Vermont Medical Society. And I really, I'm happy if you want to hear from me first. I'm also happy for Lauren to go first. I think what we say will probably be in alignment. We don't have any, where we support adding the FQHCs and the Medical Reserve Corps. In my view, that's a little different than the telehealth folks because they are still at a specific institution or organization that would know about this registration requirement. So I don't think, and that's basically parallel to the process that's already been in place for facilities. So I don't think that's as much of the concern of changing things midstream as we do have for the telehealth registration. So I want to echo, I think one of the committee members mentioned yesterday, that doesn't seem like that onerous of a process. And we agree that the process itself isn't the concern. It's more the notice piece to, I think Senator Hardy gave the perfect example of what some of the provider organizations have been talking about is the one-offs, the psychiatrist, the counselor, the social worker who's located in another state, who's followed one student or patient back to Vermont because of the circumstances of the pandemic. And while we appreciate you've added the notification requirements for when at the end of March 2022, when they need to go to full licensure, that's a little different, I think, than something changing in the next, we're really talking like the next 6 weeks here. How would those folks know? Would they, and then what are the consequences of that if just inadvertently or innocently they don't realize they have to do this? Would that then have implications for insurance billing or malpractice coverage or all of the, that's basically practicing without a license in the state of Vermont, and that could have consequences down the road that we might not even anticipate at this point. And since at least as a membership organization, we haven't heard concerns. I don't believe the licensing entities, and Lauren can speak to this, have heard concerns that our fairly strong preference would be, again, keep consistency, keep the current structure in place so we're not changing things kind of in the middle of a very busy, overwhelming time for providers and kind of catching them up in an administrative requirement. So that would be the position of the Medical Society. So thanks for taking some time to hear from us.
Thank you. Questions for Jessa? All right. Lauren Hibbert is here from OPR. So go right ahead.
Thank you. Good morning, Lauren Hibbert, Director of the Office of Professional Regulation. Thank you for making time for me today. I really appreciate it. I echo Jessa's concerns. I would ask you to not include the registry for telehealth. I think this is not the time that people are going to check back in on this authority. They may or may not have written down the date that this authority ended, but I think everyone would anticipate that it would be extended. I know that when we're wrapping up the pandemic at the end, there's going to be a flurry of communication about who can do what, where, from every licensing entity in the state. I mean, national associations are going to be sending out, make sure that you understand what's happening with your license. That's not occurring right now. Right now, people are not following, unfortunately, what the Vermont legislature is doing. They maybe are not even following what their own legislatures are doing. So, and I listened to the testimony and, Senator Hardy's example is my concern. The provider who is not in Vermont, has only 1 or 2 patients here, but is able to bill insurance, able to provide services because of this authority, that shifting without their notice, and then the ripple effects of that, as Jessa mentioned, malpractice, insurance reimbursement, potentially we could charge them with unprofessional conduct. I don't think OPR would, I don't think the Medical Practice Board would, but because we're sympathetic, but I just keep coming back to what problem are we trying to solve by changing this. And haven't seen a problem. So I would ask that you remove the registry for telehealth. I wholeheartedly support the other provisions, the other additions to the bill. I'm very comfortable with the notice requirement. As I said, I'm going to be one snowflake in a flurry when this all starts to close. So, but every snowflake counts. So I'm gonna be notifying everybody at the end, everybody who I have contact information for, and I have no problem with that new requirement on the Office of Professional Regulation or the Board of Medical Practice. I can't speak for the Board of Medical Practice, but I suspect they don't have a problem with it either. But I would ask that you remove the registry, and I appreciate you hearing me today. Thank you.
Thank you. We really appreciate your being here because it helps to clarify the issue for us. And I will see you. Does anyone have a question for you? I do have a comment before you leave, and that is, when this all ends, I'm going to make sure I'm on vacation so that all the emails go directly to OPR.
Sounds great. Well, we will receive them.
All right. Senator Hardy and then Senator Hooker.
Thank you, Madam Chair. So Lauren and Jessa, to my question that I asked just before you testified about whether the notification should apply to those people who are practicing with the Vermont Medical Corps and the FQHCs, do you think that makes sense since that would not be a new thing? Or do you think just keeping it to the people who are in a currently licensed facility, the notification?
I'll go first, Jessa, if that's okay. I don't think it's a new requirement. I think most of those folks have been requiring, I think the Medical Reserve Corps and the FHQCs have been getting people registered or having the emergency license. But I want to just echo what Jessa said. I think those are robust institutions at this point. Even the Medical Reserve Corps is now a robust institution, unfortunately, and they'll be able to understand what the requirement is and what the change is, and they'll be able to do that administrative work for the person who's working in those environments. So I see that as okay. Again, I don't see it as necessary, but I support it.
Jessa, did you want to also respond to that?
The only piece I would add is that I think it's also a little different because it's not changing something midstream for folks who already have an avenue to practice here, because you're adding these as new categories of people who can sort of come back into practice. It'll be a new thing for them. So they'll have to check the requirements, see how they go about doing that. So then they'll see that on the website of OPR or the board that they have to register, or again, the FQHC itself or the Medical Reserve Corps itself can just submit the list of names. So I think that's fairly easy to implement. I agree with Lauren. I don't know that it's necessary, but it does feel parallel to what the hospitals and other licensed facilities are doing. So I think I don't have a concern with that addition.
Okay, great. Thank you both.
Senator Hooker.
Yeah, thank you. Thank you both for being here and clarifying. I'm comforted to know that there haven't been any problems with the situation as it is, the way things are playing out now. My concern stemmed from hearing that, there might be problems with people prescribing drugs. And, we have no way to track that down. And I'm hoping that, heaven forbid, we should be in this situation again down the road, that we'll look at that, type of registration in the future. My other question has to do with the inactive licenses. How are you notifying them? And are they having to register? I need that cleared up again.
So I can answer that. If you're inactive for less than 3 years, you don't need to register right now, the way the law is currently written. If you're inactive for 3 to 10 years, then you do need to get an emergency license. And we have issued some of those. I can't parse them out, but we've issued over 500 emergency licenses since the start of this state of emergency.
Okay, and have you been contacted by the provider, or is there a notice on your website, saying that we're looking for people?
So at the beginning of the pandemic, we had given, I believe, the Medical Reserve Corps, certainly the Department of Health, lists of our licensees. We don't actually call them retired or inactive, we call them expired, but a list of our licensees, which you don't need to modify the statutory language. We just interpret all of this to fit how we classify the license. But we gave them lists of the healthcare licensees in these groups expired for up to 10 years. And I believe that there was some outreach. Certainly, we have a lot on our website saying, are you an expired, retired licensee? Are you interested in getting back into practice in the state of emergency? And here's how you do it. But we ourselves have not sent out notices to that group saying that folks are looking for providers. We haven't done that.
Okay. Thanks.
Senator Terenzini has a question. Whoop.
All right.
Now
can
you
see
got
me?
it.
I'm back. Just for clarification, we are looking, Jen, at the bottom of page 7 into page 8, and the concern is the individual. This would call whether the individual will provide services using telehealth. That's the portion that we're on, correct?
Yes, I think there's sort of two pieces of that on the bottom of page 7. The first is that on line 18, where it's struck through as part of the staff of a licensed facility and just says pursuant to subsection A of this section. So that's kind of pulling in everybody, including those using telehealth. So a healthcare professional who plans to provide healthcare services in Vermont, if it's just pursuant to subsection A, which allows them to do telehealth, and they have to submit all this information. And then also that language about whether they will provide services using telehealth. So if we were to take it out, I would modify both of those parts of the language.
And so Jess and Lauren, just so I understand, you're asking for that portion to be removed about the telehealth. Okay.
You're getting nods from both. Yep. Good. All right.
Yeah, thank you.
All right. Good clarification.
And I don't know the language about all jurisdictions in which the individual holds a license, certificate, or registration that I added in both places was something that the Board of Medical Practice had requested. And I don't know if I can ask if Lauren has a take on that. Even if it was just for people who were practicing in one of those physical locations.
Don't have a strong preference one way or the other. I wouldn't want it to be retrospective because we have people who are put on the registry and we only ask for one jurisdiction on our web form. I'm sure I could make an altercation to the web form. I don't think that is unsurmountable to ask for multiple jurisdictions. I will say that some healthcare providers have, 25 jurisdictions. So it's not, digging up your license number in all 25 is a little cumbersome. And for my purposes, one is sufficient because then I can find the person who you've identified as being responsible for you, and I can ask for your whole licensing file, and they'll certainly know where you're licensed in other states. So I feel comfortable with one. I understand that the Medical Practice Board asked for all. I don't find it as necessary, but if the committee chooses to move forward with multiple, we can adapt to that. I think the best answer that I have. We can adapt to it, but I don't see the requirement for it.
All right. That was a good question. Thanks, Jen. I completely escaped my thinking. So we'll put that into the decision-making hopper. Thank you. Okay. Committee, I think that we've heard the testimony, and I think what's really been helpful about this is really understanding what is currently happening. And the issues involved. So, and Senator Hardy's example has highlighted the difference between someone working in a hospital and someone at a distance for working with someone in another state. So, all right. Is there anyone who would like to keep the telehealth registration piece in? Okay, I see. How many of you, show of hands, would like to remove that? Oh, good. All right, so that's taken care of. Then the question is on multiple jurisdictions. Do we feel that that is an additive based on what we're hearing from Lauren Hibbert? My own thought is it's not necessary. And this is for a short period of time, and licenses can be accessed and looked up. So I'm open to anyone who would like to say differently.
I agree with you, Ginny, and thank
Okay.
you, Lauren. I think it's helpful to hear directly from the expert for sure.
Absolutely. So is there anyone who would like to keep the multiple jurisdictions in? All right, now show of hands, take out the S, the jurisdictions. Okay, that's good. I think this was a big sticking point for us, and it's good to have that clarified. Lauren, thank you so much for your time and effort on this. And also Jessa, thank you, because I know you represent a large group of folks who've been engaged in this whole thing. Thank you.
Thank you very much.
All right,
Thank
well,
you
we're going
very
to
much.
continue on with the bill. And then you're welcome to stick around and guide us further if you wish. So Jen, where are we?
Yeah, so just to recap a little bit, so as I understand it, we will take out, I definitely heard you take out the telehealth provision, take out the multiple jurisdictions, but do put in the FQHCs and the medical reserve corps as far as notification as well. That sounded like people were comfortable with that.
That sounded like something appropriate and consistent with what's been going on.
Just leave myself some breadcrumbs in here. Okay. Great, so then I can put the language back up.
Okay.
All right. So you should be seeing now section 18, which we've mostly talked about. I'll keep the language, excuse me, in the same. I can take out this specific reference to, well, I'll take out the jurisdictions piece, and I can take out the specific reference to whether the person will be providing services using telehealth. It's all sort of embedded in the intro anyway.
Okay,
did it more for consistency. And then it sounded like keeping in the notice provisions was okay. So I keep in some for as far as the expiration piece.
So let's look at that. Let's just look at that paragraph together and make sure it says exactly what we would like it to. Why don't you just walk us through it?
Sure. So this would require the Board of Medical Practice and OPR to provide appropriate notice of the March 31st, 2022 expiration date of this section, and it's the same for the previous section as well, to each former healthcare professional providing healthcare services under this section, to the Medical Reserve Corps, and to any healthcare facility or federally qualified health center at which a former healthcare professional is providing services under this section. I'm not sure if former is the right word. Inactive licensee.
Inactive relicensed. Yeah, something.
Well, they're not relicensed. Well, some of them. So the subsection B folks. Oh, I guess that was just for this piece. The subsection B folks, the people who've been out longer, do have to get an emergency or a temporary license.
Why don't we just say,
So-
why don't
so we
scroll
can
down
make it
again?
inactive.
Just say healthcare providers. Because
say
they're
healthcare-
providing services.
Sure, that works. Healthcare
You
professional
know, we don't have
providing.
to say what kind they
Yeah.
are, otherwise we'll be here all day, right? With a list.
Yeah,
Yeah, and I agree with that, and also maybe get rid of each, because that speaks to the fact that we may not know who everybody is, given what we are, the testimony we've just heard, so that it's,
right.
you know.
These inactive licensees are supposed to notify.
Oh,
the,
this just covers the inactive licensees, not the.
Yes, so here's the earlier provision. This is so I've gone back up, and sorry, it's a little hard to tell. So I've gone back up now, we're in section 17. This is the out-of-state deemed licensed folks. This is Board of Medical Practice, and OPR would provide appropriate notice to each, and yes, I can just say it to healthcare professionals providing services, if you want to leave that a little bit.
Yeah, and it
More
doesn't, and the other thing about this is we need to leave it to the discretion of OPR and the Board of Medical Practice as to when they make this announcement, because we could be right back here next year extending this. You know, we don't know. It's sort of, we don't want them sending it out tomorrow or when the bill is passed.
Right, well, that's why I gave them the requirement to provide appropriate notice so that they
Right.
could weigh the timing. And I do
Perfect.
see Lauren is back, if you would like to hear from her.
Yes, there she is.
I just wanted to add that we will likely, when the bill is passed, notify folks that the extension has been, that the deadline has been extended. So we will be sending notice when the bill passes, Madam Chair. And then obviously we would send one at the end of the term, whenever that end is, whether it's in March of 2022 or July of 2022, whenever the date is.
Got it. Thank you. That's reassuring.
All right, so I've modified it in the actual Word version to say that they will provide appropriate notice to healthcare professionals providing healthcare services in Vermont under this section, to the Medical Reserve Corps, meaning notice goes to the Medical Reserve Corps, and to any healthcare facility or federally qualified health center at which healthcare professionals are providing services under this section.
Sounds good.
Does that work? Okay. So then we get into the inactive licensees. And so again, I will take out the specific reference to all the jurisdictions and whether the person will be doing telehealth. Let me just mark that in my Word document here. And then we get to the notice piece there. And so it sounded like we were, again, going to take out the word former and just say to healthcare professionals providing healthcare services under this section. Does that make sense?
Mm-hmm.
And then similarly, to healthcare facilities and FQHCs at which healthcare professionals are providing services under this section. Okay. Great. Then we just get into some more date extensions. So this is the OPR and Board of Medical Practice emergency authority to act for the regulatory boards. You heard from both of them on this last week.
Yeah. Oh, so why don't we just go through? I'm not sure that there are any outstanding issues with any of these, but just the 10,000 foot level, I think would be helpful.
Yep. So these are the ones if they find that one of their boards cannot reasonably, safely, and expeditiously convene a quorum, then the director, and Lauren mentioned last week that she had needed to use this authority, or especially early in the pandemic, the director or executive director can exercise the full powers and authorities of their board. And then we have section 21, which is OPR and the Board of Medical Practice, emergency regulatory orders. And again, you also heard from Lauren last week that she had used this authority. So this would extend it through 2022, that the director of OPR and Commissioner of Health can issue orders governing regulated professional activities and practices as may be needed to protect the public health, safety, and welfare. And then we get into the telehealth, and this is specifically the waiver of certain telehealth requirements for a limited time. This would extend the waiver of certain requirements for telehealth, so telemedicine and store and forward, to the extent their waiver is permitted by federal law. So it's just the date that's changing, but this is delivering and representing to a patient that healthcare services are being delivered using a HIPAA compliant connection. If it's not practicable to use a connection under those circumstances, this is particularly tied into that to the extent the waiver is permitted by federal law, because the federal government had announced enforcement discretion on the requirement to use a HIPAA compliant connection to deliver telemedicine services, although it is my understanding that there are a number of HIPAA compliant services out there, including a Zoom for telehealth or Zoom for health, which I hadn't known existed before. Zoom was my good example before of what was not HIPAA compliant, and I think what we're using is not, but Zoom for health is. So it would continue to allow non-HIPAA compliant delivery modalities if it was not practicable to use a HIPAA compliant connection. And also extending a waiver of the requirement to get a patient's oral or written informed consent for the use of telemedicine or store and forward technology before delivering services, if obtaining or documenting the consent or both is not practicable under the circumstances. So again, these are not a blanket waiver, but only if it's not practicable under the circumstances. And then in the case of the first two, to the extent permitted under federal law. The third one is a purely state requirement. Any questions on that? Okay. And then we get to the Board of Medical Practice, some temporary provisions around physicians, physician assistants, and podiatrists. So this is the part that allows the Board of Medical Practice or the executive director to issue a temporary license to someone who is licensed in another jurisdiction and not subject to disciplinary proceedings, that would allow them to practice in Vermont until a date not later than April 1st, as long as 2022, as long as the license remains in good standing. So it's through March 31st practice until not later than April 1st. And then similarly, and we had looked at a little bit of a change in the wording on this, and the last draft extends the authority of the Board of Medical Practice or executive director through March 31st, 2022 to waive certain requirements for physician assistants, including scope of practice requirements and requirement for documenting the relationship between a physician assistant and physician. Then we get into this, what is now a standalone section on the DFR emergency rulemaking. So this is the section that is now split into two pieces. The first part gives authority to DFR until April 1st, 2022 to consider adopting and have the authority to adopt emergency rules through March 30th, 2022, first expanding health insurance coverage and waiving or limiting cost sharing requirements for COVID-19 diagnosis, treatment, and prevention services.
Hey, Jen?
Yep.
A really quick thing, which I think you may have just caught, but the through is
oh, it is. I did not catch that. Thank you.
Okay. And it probably shouldn't be. Yeah.
Thank you. No, I have not. I will definitely plan to send this in for editing one more time before, at least before you do anything official, but no, I had not. Thank you.
You're welcome.
So, and then any rules adopted in accordance with this subsection would remain in effect until not later than April 1st of 2022. And then separately, we have this section around the audio only telephone and other types of telehealth and brief telecommunication services. And this gives the Department of Financial Regulation the authority to adopt emergency or to adopt rules, not emergency rules, but rules expanding patients' access to and providers' reimbursement for healthcare services delivered remotely through telehealth, audio only telephone, and brief telecommunication services. And any rules adopted in accordance with this would remain in effect until not later than January 1st, 2024. And as I know we have discussed before, this particular piece is the subject of some fairly extensive legislation that is being developed in the House Healthcare Committee.
And just as an update for that, I have reached out again to the chair of the committee, and I guess they're not finished yet. So
They're
but,
not finished yet.
yeah,
I can attest to that. We're continuing to work on it, and I'm back in the committee on that tomorrow afternoon.
Okay,
When
that's
they,
good to
they
know.
may be hoping to wrap it up.
We'll put some. We'll wait for that, for them to finish some work and then bring it back to
Okay,
us.
and maybe, yes, and maybe on my official one here, I will just highlight this in a bright color so
Oh,
we don't
good.
forget about it. All right, it's now a blinding pink.
Dr. Lyons,
Yes, ma'am.
just checking. Are we passing out this bill and then doing another one? The audio only. I'm getting my finance hat on, and eventually all of this stuff is going to have to be paid for, which means it is going to go on the health insurance rates. And the audio only, I would feel more comfortable putting a fence around.
Okay, well,
So-
let's see. I think that's a really important comment, and as usual, very accurate. But it will depend, of course, on what we see for language. And so then if the language looks like it has significant, and we'll have Nolan look at it for joint fiscal purposes, do a little fiscal note. And if need be, as you have sort of suggested, we might ask to have it be a separate bill. So then it would, and in that case, if it were a separate bill, it would probably begin in the House. So let's leave our options open at this point, but you have brought up a really important point.
Yeah,
And the House's is currently drafted as a committee bill, a standalone committee bill on audio only.
Okay.
on
So
audio only, not
Right.
on. So I guess if their bill passes after this bill, then it supplants this bill in this section, right? It rules.
that's accurate.
Well, I think
That's
you're
a
right.
Jen question.
So I think it would be cleanest for, before one or both of them makes it all the way through the process, for you to either pull this piece out of this bill or put that language in instead of this. I think if they were to both pass with whatever the House currently has in theirs and this language, I think this would constrain DFR's rulemaking authority
Mhm.
in this area, because it would be in conflict with what else had been passed in statute. I think so I think it needs addressing, but right now they're sort of operating on parallel tracks until they're both in a more
So
firm stage.
are we getting, I got the impression we were going to be voting this out like soon.
Well, we're not, we are, but we are waiting for the House to complete its work and to look and see how best to proceed, given audio only.
Okay, so we aren't
Yeah,
going to vote this out until we see what the House is proposing for
Yeah,
this.
I think that makes a lot of sense.
Yeah.
And then we're going to have to resolve this issue one way or another, and that's probably a longer discussion. But
Okay.
just that you have raised the important issue for us.
Okay, good.
And to know, because this audio only goes beyond the pandemic. And that's the issue.
Definitely sets a new precedent.
Yes, it does. And we have known about this for a while, but now getting down into the nitty gritty of how it's looked at by committees, if potentially it goes into this bill, then finance could look at that section independently without having the bill go in, or this could be, I mean, because I don't know that there are other implications for beyond the pandemic, and we wouldn't vote it out until you did that. Or there's something in here that doesn't require a fiscal note. Well, that would be interesting. Or the House decides and we decide collectively that it's best as a standalone. So there are all those options, and I don't think we're ready to choose any one or
Okay.
other.
Okay, yeah, because I'm not, I would prefer having the issues resolved and in one bill.
Yeah,
Okay,
yeah,
that
we got
works.
it. I think we're on the same page with that, but we'll
Okay.
see. We'll be negotiating with the House Healthcare Committee. Okay,
Question.
that was fun. Senator Hooker.
Yes, please. Just for my edification, what would the advantage be of keeping this section on audio only in this bill as opposed to taking it out and working with the House bill separately, especially if the audio only has the potential of going beyond the pandemic?
I think it's cleaner, but the audio only is a really important issue for a number of folks. And if it's in this bill, it is somewhat cushioned from,
Okay. Okay.
is somewhat cushioned when it's
Okay.
in this bigger bill.
Okay. That's,
I think, you know, for me, there's audio only in a mental health crisis is good. Just calling up someone on MedRx or they're now advertising on TV, some lady with a migraine calls and can get an appointment this afternoon over, you know, on the phone. No physician, you know, it's a totally new relationship. Having that go beyond, there's healthcare concerns. There's just quality of care concerns. And I think is a phone call. And should I be able to charge my insurance, you know, the insurance company the same for a phone call for me to call up and say, you know, my kid's got an earache, as opposed to going in and having the ear looked at and all the rest of it.
What, so
That's cost
Senator, we understand that. And I think we've heard that testimony that's, if we want to dive into this issue with all the testimony that the House has had, we can do that. We're trying to get this bill completed because it is a pandemic bill. And we'll listen to what the House has to say. And then if we need more testimony, we can certainly get that.
Yeah, I think it needs to be dealt with. I'm concerned that if we do this and then the House comes in with something else, we get into.
We're not going to do this.
Okay, that's good.
This is not what we're going to do.
Okay.
Remember, there's a report that was out and it had specific recommendations. And so now the recommendations are being reviewed by the House Healthcare Committee and all of the stakeholders and players that are engaged in this. There is a place for audio only. In the past, we also understand that folks have not been reimbursed for all of the audio only that they do. And so finding the balance so that we do have appropriate and clinical outcomes at the same time supporting providers. I think those are you've brought, all those issues have been brought up and they're right on target. Senator Hardy, you had a question.
Well, I mean, this is obviously a longer discussion. I'm curious, I'll be interested to see what the House language comes up with, and that would sort of form my opinion about this and then listening to the testimony. But my impression is that we're not talking about the kind of example that Senator Cummings gave with the, calling some random service that's advertised on TV. This is about actual medical providers who are licensed in our state or have the provisions under these emergency provisions to provide health care. But again, I want to see what the House comes up with, because it feels like we're into weeds that the legislature isn't usually into. And so, yeah.
Well, that's exactly why that report is so critical, and the House taking the lead on this is also important. So, we're still in the process of figuring out where we are, and I have reached out to the chair of that committee a couple of times. I know that everyone's busy, but I'm hoping that we'll have that conversation before next Monday. We're working on it.
Okay.
All right, Jen, let's keep going. We could talk about this one all day and not resolve it
Okay.
because we don't
I-
have sufficient information to do it.
Senator Lyons,
Yes.
I just had one other question. I'm looking at C, and it says the department shall consider adopting.
Yes.
Is that?
Yes, that's been the language. It's been the
Okay.
language throughout on this piece that they would consider adopting and have the authority to adopt.
Okay.
It's not
I just
particularly
thought
standard.
shall is a hard you will, and
You
then
must
shall
consider.
consider just.
Yes,
Yeah,
I think
okay,
at
so
least
I thought about it. Goodbye.
at least when this started back in Act 91, there was interest in making sure that it was on DFR's radar, but not tying their hands in any particular direction.
Okay.
And this the DFR has worked very hard in the emergency rules that it has developed. And they've called everyone together. They're very conscientious about the work that they've done, as you well know.
No complaints.
All right.
Okay, so
Let's put
that is
that discussion behind us for now. We'll be back.
all right. Section 4 is the language we looked at last week on advanced directives and extending the time for those remote witnesses and explainers. So this allows an advanced directive that was executed between June 15th and 2020 and June 30th. This would be 2022 to be deemed valid, even if the principal signed with outside the physical presence of one or both of the remote witnesses, if certain requirements were followed or certain conditions were followed. And similarly for somebody who was being admitted to or was a resident or patient of a nursing home, long-term care facility, or a residential care facility or hospital, if the explainer explained remotely, that's okay too until June 30th, 2022. We did give an overview of this language to the House Human Services Committee yesterday, and they heard from the witnesses you heard from, Cindy Berzesi and Olivia Graffio-Cohen from Vermont Legal Aid. So they have an understanding of this when it comes over as well. And then finally, we had section 5, which is that immunization registry piece that you talked to the folks from Vital about last week. And you had asked me to put more language in here for context about what this immunization registry is. So this is all existing language you can see right now in subsections A. So subsection A is really talking about providers reporting. Subsection B says the department can create a registry. Again, this is all existing law, but you had asked to be able to see it. Subsection C, the department can exchange confidential registry information with those in other states. And then here's where you made your change in subsection D that allows the Department of Health to provide confidential registry information to the Vermont Health Information Exchange. And then when I was looking at at what language from the existing law to put in or not, I noticed that in subsection E, it talks about prior to releasing confidential information, pursuant to subsection C and D, the commissioner must obtain from whoever is getting that information a written agreement to keep any identifying information confidential and privileged. I wasn't sure if this was strictly necessary because I think Vital and its operation of the Health Information Exchange has certain confidentiality requirements, but given that there was this provision specific to all other recipients of information, it seemed appropriate and maybe sort of a belts and suspenders to put it in here as well. I did run it by both Vital and the Health Department, and there were no objections there.
Oh, thank you
that's
for
why
doing that. Yeah,
That's
no,
why
that's
this is
good.
bold and highlighted.
We like
That's
belts
it.
and suspenders.
Right, it didn't hurt anything, and it might either help or at least help people feel more comfortable. And it seemed a little glaring in its absence from the list when everyone else was on the list of
Okay,
written agreement for confidentiality.
excellent.
Thank you, Jen, also for providing the other sections for context. I think that's helpful for people understanding it.
Sure, yeah, and I mean, I think, no, I don't always have to provide that much for context, but because it sort of it progresses from provide data, create a registry, here's who can get the registry information, it seemed like it all sort of made sense in there. So I'm glad that's helpful.
All right, good. This is good. So with the exception of the audio only, how do we feel about the bill at this point? Good? Are we all good? Is there anyone who feels uncomfortable about any one or more sections? No. Okay. So I think what we'll do then is we'll sort of set this one aside until we hear, I've had an opportunity to talk with the House committee, and we'll just stay connected with that whole process that we've just talked about. Senator Hardy.
Yeah, I appreciate that, Senator Lyons. I just want to make sure that whole mishigosh doesn't hold up the bill.
I don't think it will. That's the whole point. We want to. I've been trying to be a thorn in the side a little bit. Not really, but just to just maintain contact and keep things moving along. And I know the House is very concerned about this, and they're also feeling, I think, the same way you are about getting this bill out. It has to go out before crossover, and it has to be passed before March 31st. And we know what happens around the State House. Things get problematic. So
I think there are a lot of nervous people out there, so they want to make sure that they
can have full confidence in our ability to get our work done. Let's hope. All right. Anything else you want to say about this bill? Cool. Here's my suggestion. So Jen, you're around today, and I know Katie is unavailable. So I think what we'll do is, what time is it? Yep, good timing. Let's take a little break. When we come back from the break, we're going to talk about S42 amongst ourselves. And then I've asked Jen to introduce another bill that we have in our committee, S22. We should have plenty of time to do all of this. Don't you think, Jen, to go through S22 too? Okay.
Yeah.
Yeah. All right, good. So let's, Nellie, why don't we put the screen up and we'll take a little break. And FYI, I should let folks know that, thank you, Lauren. I should let folks know that when we go on break, we're actually not any longer on YouTube. So we go, YouTube is off, but we stay on Zoom. We're still in Zoom, so you don't have to do a thing. But this helps with any noise in the background and keeps us more secure. So Nellie, we are ready to take a break. 15 minutes.